CT scan we have done, we have staged it, and like we check the blood test and IL-6, serum ferritin, D-dimer, LDH. This is the test we can do. Okay, so when we see there is continuous worsening of the symptoms and everything, we would do those tests and we would assess it on the severity. And like what happens, how the patients, like what is the mainstay of disease process is that we have to treat the moderate COVID, and we have to prevent the patients of moderate COVID from going to severe COVID. So like that is the mainstay of treatment. So what happens, how the patients goes from moderate COVID to severe COVID? So that's what happens. The viral replication starts, and the viral replications weans off after a period of time. But what happens, in order to combat those endothelial epithelial injury, I've told the virus reaches endothelial epithelial cells, epithelial interface areas. In order to combat that, there is a massive release of cytokine. So this massive release of cytokines is seen in most of the papers. We don't know why this happens. So like in some papers we have seen the massive cytokine being released, but in some cases like the immune system doesn't release that sort of cytokine or so, and due to the cytokine release, the body goes into cytokine storm also. So the cytokine storm, we would see it is mediated by Th17, which releases IL-6, then D-dimer, then other ferritin and LDH. So yeah, so this would get elevated around the 5 to 10 days or so after getting the infections. So in severe COVIDs, how to see it, like it is severe COVID or moderate COVID, and their SpO2 levels would be less than 90%, and respiratory rate would be more than 30 or 30 breaths per minute. And because of this cytokine release, I've told you can do this investigation, IL-6, serum ferritin, D-dimer and LDH, and this cytokine release or so, this leads to a coagulopathy. The coagulation profile is deranged in the body, so it leads to micro and macro angiopathy. Means there is a lot of thrombosis formations, and also so to prevent those thrombosis also we give LMWH, low molecular weight heparin we give the patients. So like who are the persons who are having a risk factors for the COVID also, like they are have a higher chances of mortality and morbidity of COVID, like it includes COPD, diabetes mellitus, then other hypertension, sickle cell disease and this obesity also, and post transplant patients also have a high risk of progressing to much more mortality and morbidity conditions. So like the treatment per se goes like for the mild COVID you don't have to do much, like there are drugs like favipiravir, hydrochloroquine, which have shown the promising results. At the hydrochloroquine, favipiravir drug which has showed some result on the initial stage, but now there is no much, because patients we have like there are patients dying because of hydrochloroquine, because it increases the QT prolongations that we read in pharma, QT prolongations, and patient can die of arrhythmias or so. So it is not so much of effect that the research is going on, and so so there are other drugs like ivermectin has been tried, and like the patients can respond also in mild and moderate COVID we give it. and mainstay is paracetamol, and this hydrations, multivitamins and so in this we can also give it in moderate COVID patients also, plus antibiotics which should prevent any sort of infections also. Antibiotics are mainly the broad spectrum antibiotics that you can give, like meropenem, ceftriaxone, and other things, piperacillin, tazobactam, and other things we can give. So, like, let's say the patient's coming, like we do the CT scan mainly on the 5th or 6th day after getting the infections. If we want to do this, the patient is not progressing, he is deteriorating or so, we do a CT scan. Along with this, we do those test IL-6 D-dimer and see and rate the patients and see how can we treat or so. So, but in moderate COVID patients, we have to give, because we have to prevent the patients from going to severe COVID. Okay, so to prevent, so we would give the patients steroids, mainly methylprednisolone or dexamethasone. Dexamethasone is generally used. Dexamethasone is 6 times more potent than methylprednisolone, so we can give it. And along with this, LMWH because coagulopathy and COVID, LMWH or enoxaparin we can give. Along with that, we can give what, antibiotics also. Antibiotics are broad spectrum antibiotics, meropenem also, and some cases we can also give budesonide, inhalation of budesonide. It's also a steroid. Or levosalbutamol, it will dilate the bronchus also, and this would prevent any sort of consolidation formation also. So these are the drugs, good drug. It's a good drug, budesonide. We can give it as a transhallar or we can give it as a fumes also to the patients. So and then we'd give also the ventilatory support. We talk little bit further on this video. So now with ventilatory support, and we have to assess the condition is improving or not also, but we have to give the ventilator support. The patient needs oxygen, and we have to decide that whether the patient needs remdesivir also. And in severe COVID patients, if there is a cytokine storm also, like we can have to boost up the dose of dexamethasone or methylprednisolone, and we can add remdesivir. Here in moderate COVID patients, the remdesivir is given for 5 days as a bolus of 200 mg on the first day, and of 100 mg for the remaining days, OD dose. And here remdesivir we give it for 10 days or so, as same as bolus double dose, and then with half the dose as soon as the day progresses. Okay, and we can try tocilizumab also. Yeah, this is a cytokine storm, so not much data evident, but yeah, the studies there have been some studies done and seen, yeah, the tocilizumab drug has a good benefit, but still it's going on. So yeah, let's see. And the patient should have a ventilator support in every cases there. Okay, now the ventilator support that you can give in COVID patients. Ventilator support. Okay, so now ventilator support that we can start with mild respiratory distress cases. Patients have mild respiratory distress, we can start with the nasal cannula. So nasal cannula can provide a flow of 2 to 6 liter per minute, and FiO2 about FiO2 40%. FiO2 we can know the fraction of inspired oxygen. What FiO2 you are taking at room temperature? 28%. So it can provide an FiO2 of 40%, and we assess the patient how he is responding or not. So nasal cannula, how it is, it is just like this. We can say this nasal prongs, and there are with tubing connecting to the machine or so, and it will be going. This will be attached to the patient's nose or so, and it will deliver the oxygen. So if you see the patient's saturation doesn't improve or so, like the patient saturation is around 80 to 88% or so, the saturation is not improving, then we can try a Hudson mask. Hudson mask. It's a mask which can provide a flow of 5 to 10 liters per minute, and it can provide an FiO2 of 60%. So this 60%, and this mask you can recognize it's a mask, and like from there is a connection which goes into the to the central line of the oxygen, and this mask the patient wears, which covers the nose and mouth of the patients. This is a Hudson mask. Again, if the saturation doesn't increase, and so then we can have to do apply a non-breathing mask. It is, you can see this mask contains a bag attached to the mask. Bag is attached to the mask, inflated bag. We have to keep the bag inflated most of the times. It shows the person's expiration volume also. It gives an idea also. It can provide a flow of 10 to 15 liter per minute with FiO2 that it can provide. It's 90 or 80% of 90 or 80% of FiO2 or so. So one important thing that we have to look is that as we go on increasing the oxygen flow or so, there is an increase risk of aerosol production are lethal, that can affect the healthcare workers working in the ICU, or it can affect the other person. So like we can apply a viral filter to the tubings of the patient, so that the viral filter purifies it and doesn't let the particles to come out. Again, if the patient is not responding to all this, this non-breathing mask, I have to tell, okay, it's a mask which has it's a mask, and then it will have a bag surrounding it, and from this the mask it covers the nose and the mouth of the patients, and there is a bag which we have to keep it in a filled up positions, and from there the tubes would go and reach it. And yeah, so like if the patient's oxygen is not improving, then we have a choice to go for a CPAP. CPAP means continuous positive airway pressure, and BiPAP. Okay, I tell about it later. What happens in continuous or BiPAP? BiPAP is by positive airway pressure. So like how to differentiate between CPAP and BiPAP? What happens now? CPAP, and now one more thing, that before telling about the difference, these are methods of non-invasive ventilation. This is also non-invasive ventilation. Okay, so the thing we have to do from here to here, the maximum aerosol production will be this thing produces maximum aerosol production. Okay, so how to differentiate between CPAP and BiPAP? CPAP means produces a continuous pressure, both at a same pressure between inspiration and expiration. Like suppose we set a CPAP device at a value of 8, so it would provide the 8 centimeter pressure of water at both inspiration and expiration. So why it is important? Why it is important? Because it at expiration it doesn't prevent the alveoli to get collapsed or so. Then we like this CPAP device, we tell about it in further of the video. And in BiPAP videos, what happens, their inspiration and expiration we can set at our choice. Generally the inspiration we choose is 8 and expiration is choose is 4. So we can choose both inspiration and expiratory pressure both in BiPAP, but in CPAP both inspiratory pressure and expiratory pressure we can say it is IPAP. IPAP is equal to EPAP, where IPAP and EPAP both are variable, so we direct it in BiPAP. Change like the values change. IPAP is inspiratory positive airway pressure and EPAP is expiratory positive airway pressure. So this thing is clear. Okay, so when we would we have to be aware that this CPAP and BiPAP has a mask, and this mask is not, well, sometimes the patient doesn't have a poor compliance for the mask, and the patient's coordination is really well required for this mask to function, because it does provides a high flow oxygen and everything, but because some of the mask of the CPAPs covers the entire of the face or so, and the patients are not feels really uncomfortable also. Again, we have to be careful. We shouldn't use the CPAP or BiPAP machines in the raised ICP cases, and other contraindications are there for CPAP and BiPAP. So again, we can see if the patient still is unconscious and like the patient is really sick, or so he is having altered sensorium, then we have no choice but to in altered sensorium and not maintaining proper airway, maintaining proper airway, we have no choice but to intubate the patients. So in the COVID era, so we can see intubation that we have to do, the direct intubations, where we would put the blade of the intubation, and then we would see the epiglottis, pull it up, and we'd intubate, put the endotracheal tube and come out. But like in the COVID era, that we are doing what, video laryngoscopy. So in there, instead of seeing the patient's epiglottis or so with by our own eyes, or so we'd have a camera attached to the tip of the blade, this Millard blade or McIntosh blades, so, and then would see it in a video of it, and when you see the epiglottis, we lift it up and we put the endotracheal tube. Also, it has a reduced chance of generating the aerosols, or it maintains the patient's both like safety of the healthcare workers also. So video laryngoscope is really in use for the COVID, and so yeah. So after this we have to see, we have to do the intubations and put the endotracheal tube. And one more thing that I'd like to add, before doing the intubation also, we have to oxygenate the patients, pre-oxygenate the patients, so that because for the intubations, and we connect the nasal cannula providing a high flow oxygen, about 15 liters, how much it is possible, and then we'll go for the oxygenation, because the intubation is a difficult process. It's like it will take some time to see the vocal cords and everything. So we want the patients to get a really proper sort of oxygen also for 2-3 minutes or so. Then we'd go for the endotracheal tube and we'd do the intubation also. So we have done the intubations, we have connected to the ventilator. So what the ventilator provides is that main important function is PEEP. PEEP. PEEP is positive and expiratory respiratory pressure. So this PEEP, positive and expiratory pressure. Now be let's be attentive also. So this is the alveoli, okay, normal alveoli, okay. Normal alveoli before the inspiration, after inspiration it gets inflamed, and after inflame when it returns to the normal state, so the expiratory state, it decreases state. So there is a pressure because of the elastic recoil, the lungs return to its normal state. But because of the disease per se, which happens in the COVID, I have said there is a decrease in the lung surfactant. So because of this decrease of the lung surfactant, the alveoli doesn't come back, it collapses, it gets collapsed. So it gets collapsed. So because of this collapse, and once the alveoli gets collapsed, there is no force that we can apply to open those alveoli. Those alveoli can never be opened. Once it requires a tremendous amount of force. Means collapse means this is the bronchus, and the alveoli becomes shut off this. So to prevent this, we have the positive and expiratory pressure, which provides a continuous airway pressure during the time of expiration also. In expiration, what happens? This relaxes elastic recoil. There is a negative pressure, mainly this negative pressure. But what happens in PAP? We provide a positive pressure at the expiration also, at expiration phase also. So it avoids the collapse of the alveoli. We remember that we had seen in the CPAP also, there was a continuous positive pressure that was generated. Continuous positive pressure was generated both at inspiration and expiration. So we can say that CPAP is equal to PAP. But the CPAP is a non-invasive technique. We don't have to put any endotracheal tube or anything. It's just a mask that we are placing, and then we are doing. And in PAP, we would intubate the patients. We would intubate the patients, and then we connect it to the ventilator. Then the ventilator does it. So yeah, and in COVID patients generally need a high PAP of 15 centimeter of water or so. So yeah, and when you connect to the ventilator also, we would give a oxygen of 100% oxygen, 100% O2 to the patient. So this 100% FiO2 of 100%, and then we would see the response. How the patient does, and then we take an ABG, arterial blood gas, and we'd see how the PaCO2 and analysis. I'll tell about it further. Now, like one more thing that I want to say, that in PAP there is a condition like in obstructive lung diseases like COPD or like asthmatic patients. What happens, like the property of the lungs to come back to its expiration phase is reduced. So there is sort of, we say that there is sort of air trapping. There is a lot of CO2 gets trapped in COPD patients, and COPD patients are a poor prognosis of for the COVID. So what happens because of this air trapping? Look, now there it is, the inspiration, there is going, then expiration, inspiration, expiration. it's inspiration then expiration, inspiration expiration. But what happens, I would change the pen. What happens in COPD or so, like this is the normal, this is the before the inspiration, before the PEP has gone, and then we provide the inspiration that is enlarged. But look, it hasn't returned at the phase of expiration, it hasn't returned to its original phase. That's slight dilatation, there's slight dilatation. So it has reached the inspiration, but it hasn't reached a proper state or its earlier state, because there is a lung pathology or so, because of the COPD. It couldn't get elastic recoil is not so much sufficient to get to its original form also. So there is a little bit of air trapping, hasn't touched the baseline of it, and then again the PEP comes, and there is a positive ventilation, then it increases. So like this, again the next cycle it increases and it again goes. So there is a sort of air trapping also, this air trapping also. And this is, we can say it is an auto PEP. We can say it is an auto PEP because there is an air trapping which happens in this COPD patients also. So now, like one more thing that I can add on to is, like when we give the oxygen, like ventilation, we give the oxygen also, there is like we know, like when does the heart receives the blood also, between there, when there is a little bit of negative pressure also, there is preload and after, there is a preload, there is afterload. So when there is a vacuum created, a negative pressure is created in the chamber, thoracic chamber or so, or the heart receives this blood. So when but in ventilation there is a prolonged maintain of this pressure, so that the blood cannot reach the heart, because there hasn't been so much of negative pressure that can be generated. So generated in the thoracic cavity. So the blood, like the blood coming from the IVC or SVC, there is not so much of negative pressure that can be generated. So it decreases the blood flow to the heart. Decrease blood flow to the heart means decrease in the preload. Decrease in the preload, which affects the afterload also. So because of this, there is a decrease in cardiac output. Because of this, there is a decrease in BP also. Again, similar, the blood is coming from the up to the from SBC. Again, there is also change in up from the SBC, and SBC receives blood from head and other brain also, and brain and other structures. So again, if there is a increase of so much of pressure because of ventilation also, because it is a positive inspiratory pressure, because of so much of pressure that we are providing, that would affect the downstream of the blood that is coming from the brain also, downstream of the blood that is coming from the brain also, and it would just create such a block sort of stuff for the easy flow of blood from the brain to the heart also, and to decrease the cerebral perfusion also. So it would there can be changes of the ICP, intracranial pressure would also change. So main purpose of putting on the patients on ventilators, we are not free of it. We have to look at the patients, and we have to see and monitor everything. We have to send the patients for the ABG or so. We have to see how is the PaCO2, how is the PaCO2 of the patients, how are the saturations of the patients, and everything. If like the PaCO2 of the patient is after we have placed the patients on the ventilator with 100% oxygen is around more, it should be less than 60 mmHg. It should be less than 60 mmHg. If the PaCO2 is less, or the oxygen after applying the 100% oxygen, FiO2 of 100, if the oxygen is is higher, the oxygen is higher like 400 or 300, then we can reduce the FiO2. We can reduce the FiO2, we can reduce the FiO2 and see the patient requirement, and we can reduce the FiO2. But initially you have to start with FiO2 that the ventilator provides is 100% O2. Then after assessing everything, ABG also, then we will be assessing the patient's clinical conditions, how it, so we reduce, and then our main aim is to reduce the FiO2 to 40% of FiO2, and then we gradually weans and see the weaning has happened, means the patient is recovering, and then the and after some time the patient recovers, and it's really good happening that the patient gets discharged. Thank you.